Welcome to Recovery Equity, a series of conversations about how we can reach and help more people find freedom from addiction. This is a space for us to reflect on some hard truths and to consider ways forward and even new possibilities. My name is Demir Ertzen, and I'm manager of mental health services at the Hazel and Betty Ford Foundation. I also have an adjunct assistant professor appointment at the Hazel and Graduate School of Addiction Studies. Today, we're discussing the Asian American experience with focus on the intersection of migration, healthcare, and addiction. I'm grateful to have this important discussion with friend and colleague, Dr. Cuong Pham. Dr. Pham is assistant professor in the Division of General Internal Medicine at the University of Minnesota Medical School. He is also a practicing physician at the Community University Healthcare Center. He has expertise and passion in working with varying cultural experiences, including migrant health and marginalized populations. Welcome, Dr. Pham. Thank you for taking the time to be with us today and sharing your incredible expertise.
Well, thanks for having me this morning.
So before we get started, would you please share a little bit about yourself, specifically your experience and the source of your passion for working with migrants?
Sure. Yeah, I think it's always important to talk about our own identities because this really does matter for how we interact with patients or our communities in general. You know, I'm Vietnamese American. I came here at the age of a year and a half. People use the term boat person, boat people. I came here with my parents overall. So that kind of describes of my past. Some people call me like a 1.5 generation immigrant generation overall. So I'm an immigrant, I'm a refugee. My family was displaced because of the Vietnam War. But a lot of those experiences come from my parents and what they dealt with due to the war and their choices. I came along for the ride. So often a lot of my experiences is often being a Vietnamese American in the context of the suburbs of the Twin Cities overall. And so my experience is very much a white experience with my colleagues going through medical school and residency here today.
Well, thank you for sharing that. And, you know, our viewers or listeners may not know that, as I mentioned, we've known each other for several years now, and the experience we share is that of refugees. And I have the advantage and privilege of appearing mainstream, of being white and a male, and for lack of better words, passing through the community. And yet there are other parts of my identity of being marginalized and coming here as a 10-year-old, not speaking the language and having to navigate some of these challenges that you mentioned that I'd like to talk a little bit more about today. So before we get started, you mentioned your personal background and what kind of drove you to do what you're doing today. And migration-related issues have taken center stage over the past few years, given their sociopolitical impact. Yet there's a lot of confusion behind the legal terms. You know, you mentioned being a refugee, which I identified with, and yet the colloquial term that is often used is immigrant. Would you briefly talk about those differences between immigrants, asylum seekers, and refugees?
Yeah, I think it's important for us to know those differences as providers, as communities. That interaction might be slightly different when you work with a person that self-identifies as an immigrant or a refugee. They might not even use those terms overall. But as I mentioned, an immigrant is a person that often chooses to leave their home place or home location due to many factors. You know, usually we talk about more for economic changes or relationships in general. Refugees, they leave because of violence, war, nowadays climate change. Like I said, my family left because of war, and then afterwards the issues with war and the discrimination my family was receiving from the communists in Vietnam. Those experiences are so different for those populations. The trauma that refugees experience, not wanting to leave their home country, always desiring to come back to that home country. And then my experience too, as a child, seeing the trauma my parents experienced growing up, funneled through me and my choices why I became a doctor too, and what I see in different cultures over time.
Yeah, you bring up a good point. And the immigrants are typically motivated by economic reasons. As we know in the United States, those are typically referred to as immigration type visas for professionals, whereas refugees are forced by whatever factor, socioeconomic or otherwise. And asylum seekers are in that uncertain place of not really having refugee status, but not also being able to go back to their home country. So I imagine that you also interact quite a bit with that population or subset of that population in your medical practice.
Yeah, so since I work at the Community Universal Healthcare Center, we serve a lot of people who are, one, don't have insurance, two, are undocumented. And those undocumented people are often from Mexico, Central America, other Americas in general. And again, they leave because of violence they're facing in their home country, or now, again, climate change. Um, they don't want to leave. They
Right.
want to be back home. That's where their natural habitat is, where they can be in contact with their family, their traditions overall. So it's hard for them to show up in my clinic, often not speaking the language, or having English is really their second language. And it's hard to kind of tear down the pieces, what they're dealing with in general. And on top of that, I think we don't use the word asylee quite often for those
Mhm.
patients. We call them illegal. And we put stigmatizing terms to people that are hardworking humans like everyone else, trying to ascertain basic human rights, shelter, food, love like anyone else.
That makes me think of trying to bridge these dual identities that I've even had, right? On one hand, I can pass in the mainstream. On the other hand, I hear things that people wouldn't otherwise say to me had they had any understanding of my background. And that's such an important factor. So when you think about your personal experience, your professional training, what have been some unaddressed components of treating migrants struggling with, comorbid addiction and mental health issues as a result of fleeing violence and persecution?
I think the hardest thing is I enjoy school. I love school, right? I've been a lifelong student. But school only gives you kind of the framework, kind of the ideal situation of all our patients. And we can talk about concepts like cultural competence overall.
Mhm.
These are important topics, but it only gives you a window to what's going on in a person's life. And often I think sometimes we lean on these knowledge topics, but don't spend the time of learning about cultural humility, where you sit down one-on-one and really learn about the individual. So I think like you were mentioning about your own identity, it's only kind of the superficial window that we have of ourselves, but there's so many more depth of that identity and deeper within your inside yourself that we have to sit and kind of listen and understand those questions. So I think school, again, provides the framework for me. And I enjoyed and loved going through the university through my years, but not until I sat down and started to listen to my patients, and on top of that, engaging with the community and learning more about the factors that, one, either helps them engage in their care, or two, the barriers they suffer on a day-to-day basis to get care, whether that's just healthcare in general or addiction care too.
So, how do you bridge that gap from education and training that's formalized and doesn't necessarily apply directly to caring for migrant communities to being just curious, kind, and open to different experiences?
It's always realizing, so cultural competence is important, but knowing that it's fluid. And so being okay to relearn and learn. And then with the cultural humility, always being okay with making mistakes, and then
Mhm.
listening and asking questions. And then being willing to have mentorship and building those connections with the community. Because even if I might learn something from one individual, that one person is not the monolith for the entire culture overall. So sitting down and having the community come to your clinic, having the community come to wherever you work, and having that one-on-one conversation with everyone, all the stakeholders involved in that care would help you make those differences where you can bridge that gap.
And medicine has been always on the forefront of advancement, and historically there have certainly been aspects of it that are marginalizing, but there's always an effort as well, I think, to break down those barriers. What about the intersection with social policies and with laws that are restrictive to some degree and prevent accessing that care equitably?
Well, that's a hard topic, right? Because I think as providers in the healthcare field, we forget about those things, right? It's like we're sitting in that room with that person, and we forget about all the issues that go around that individuals for those barriers overall. Um, I think there are awesome nonprofits, organizations that are working really hard in the Twin Cities, in Greater Minnesota, where they are thinking about policies and they are
Mhm.
connecting with our leaders in Minnesota those are opportunities for us to learn those structures better. In medical school, we do learn a little bit about how the healthcare system works, but again, it's just so superficial. Until you see those nuances that happen to our patients, you may not recognize it overall. And our policymakers, I think they're trying their best too, but sometimes they don't recognize the domino effect that can happen to families, individuals, that again can cause barriers. So I think for me, really is continue to have those conversations about with the community and say, hey, what are the things that are really stopping you from having the right care that you want, that you feel that it's more culturally attuned to your needs? Until we have those conversations, I don't even know what the policies that need to be changed at all.
So it sounds like really becoming comfortable with that uncertainty and a parallel process that migrants have to go through, that they have no choice, and replicating it in the clinical context, right?
Yeah, and I see ourselves as citizen providers. I see myself as citizen physician, right? I can't disconnect these two parts of myself overall. I can't walk in the room and assume I'm a physician, that's it. I'm part of the community. I have my own identities I care with. Some of those come with biases. Some of those come with thoughts that help me connect with those individuals better. But it's my job as an individual, as a citizen, to learn as much about everyone as possible.
So embracing a human rights ethos in our practice, which again is not necessarily taught in formal education, but we have to learn our own.
Yeah. And the cool thing I think nowadays is I have a lot of peer mentors, and I would include you as a peer mentor too, where we start connecting with each other and realize these are things that we can build on top of each other and start learning and spreading that knowledge we need to do better for the community.
I think you're very humble, because I also see you as a mentor, but it speaks to really the formalities of having conversations, discussions about really difficult things in a context or a setting where there aren't going to be necessarily challenges to beliefs, and we each can hold our own truths without having to agree or disagree.
Yes. Yeah. It doesn't have to be a debate. It doesn't have to be an argument. It's just a place to listen, a safe space to share, and a safe place to learn and love each other.
And if you could leave our viewers and listeners with a suggestion or some advice on working with this population, what would that be?
One, jump in. We need more providers. We need more people who are passionate about learning and connecting. It's okay to make mistakes. It's actually a good thing to make mistakes. But at the same time, let people know that when you make a mistake, that you're willing to take feedback and make changes. That's a sense of being just open and tolerant and sharing with others.
Well, on behalf of everyone watching or listening, I want to express my gratitude to you for taking the time to speak with us today. You've given us a lot of things to think about in our practice, but also in our advocacy efforts. And to everyone else out there, please let your friends and colleagues know about these conversations and come back often to catch more episodes of Recovery Equity. Because together we can build a healthier, happier, and more equitable world.